Now time to shift gears over to multiple myeloma. And Ola, it's great to have you here and your perspectives on a number of the different abstracts that are going to be presented. One of the things that we wanted to start with was the concept of smoldering myeloma and the high risk of smoldering myeloma. We were talking before the discussion about the fact that some of this is semantics as to where you draw the line and the parallels between other lymphoid malignancies and kind of the early disease or early stage versus later stage. And the concept of smoldering myeloma seems to be more and more important for people in practice to understand. So before we get to these abstracts, just a minute or so on kind of what is smoldering myeloma and what are the key points as one thinks about it?
Well, I think you really focus on a very important area. I see this a lot in my practice. I get a lot of referrals, and a lot of private practice doctors don't really know, is this myeloma with the new criteria? Because the new myeloma criteria were updated just 2 years ago. So you don't have to be sick to be called myeloma. There could be biomarkers. So I think the long story short is that smoldering myeloma has certain criteria. You are not supposed to have any of the end organ damage with renal failure, anemia, bone lesions, and those types of things. And also there are 3 other biomarkers. There are the light chains being over certain thresholds, high plasma cell infiltration in the marrow, and or MRI changes in the bone marrow. If you don't have that, you could now fit still with a smoldering category. I think it's important here to say that at this point, there is still no FDA-approved drug for patients who do fulfill the criteria for smoldering myeloma. So if you have more than 10% plasma cells and or if you have an M spike greater than 3 grams per deciliter, in the absence of these myeloma factors, you have smoldering myeloma. And you should not treat this patient outside a clinical trial. That's important. But I think the field is changing. And that's what ASH is really kind of shedding a lot of light on.
Yeah, so there are a number of very interesting studies. I think we're just going to hit a couple of them, but one was a study from Matheos, which to me is kind of, in some ways, very aggressive, in the other hand, some ways smart, in that this is like throwing the kitchen sink almost to a smoldering myeloma patient, and you can say, well, wow, that's overkill, or you could say, well, maybe you're going to cure patients with this. So what's your take on this study, and tell us a little about it?
Yeah, so the Matheos study is a kind of a follow-up on 2 other studies that have been done in the past few years. In 2012, this same group from Spain, Matheos, they published in the New England Journal a randomized study between lenalidomide dex versus observation. There were 60 patients in each of the 2 arms. And they found that that was associated with a better both progression-free and overall survival. So as a follow-up on that, we led a study when I was at the NCI where we added carfilzomib to Revlimid dexamethasone in a single-arm study. And we showed in that study that you could have 100% complete response rate, and there were 95% or so MRD rates. So it would make sense to see, could you expand on that? And that's exactly what this study is about. So they enrolled 90 patients across Spain in a multi-center fashion, and they treated them with the same therapy we used at the NCI, but they also added transplant. At this time when they presented at ASH, this is the first presentation from this study. They only have a few patients who have completed all the therapy. And so far the numbers look very similar to the NCI study, but I think the key question will be long-term, will there be a big difference if you add a transplant or not in terms of efficacy? And it's too early, but I think this study is going to be important. It will answer an important question. Shall you use your most aggressive treatment up front? We don't know.
So do you think ultimately we'll end up answering this question by some sort of big randomized trial of kind of not much therapy or no therapy versus this more aggressive therapy? Do you think myeloma groups seem to have done those sorts of trials much better than we have, I'd say, in lymphoma.
So there is actually already a study coming very soon using the same regimen that was done at the NCI with the KOD without the transplant in a randomized study versus Revlimid dexamethasone. And that's going through the European Myeloma Network, and there are also participating sites. We are opening it at Memorial as well.
Good. Okay, great.